Okay, hello everyone. My name is Dr. Yutan from the University of Toronto. Myself and the speakers behind me welcomes you to the IOS virtual webinar on airway and gastric point of care ultrasound, or POCUS, in anesthesia panel. And before we get going with the presentation, I'd like to just talk a few things about housekeeping comments. Just 1 second here. Okay. First of all, this virtual presentation has no commercial support as a disclosure. And to remind everyone that there is a AMA credit for this presentation of maximum of 1. And this presentation is recorded. And if you have any questions at the end of the live Q&A or during the presentation, you can put that in the Q&A button below. And again, I'd like to present our speakers. Myself again, I am one of the associate professor at Mount Sinai Hospital from the University of Toronto. I'll be moderating this webinar. And behind me are the expert panel speakers, including Dr. Cristian Arzola, who is in the middle. He's also an associate professor from Mount Sinai in the same institution. And on my left-hand side is Dr. Naveed Siddiqui in the same institution. He's an associate professor. And on my right-hand side is Dr. Fabricio Zasso, who is an assistant professor. They'll be the expert speakers on gastric, upper airway, and lung ultrasound. And as a reminder, at the end of the presentation, we're going to have a live Q&A, and I'll be answering any of your questions in the Q&A box. Okay, with no further ado, I'll proceed with the presentation. And as a reminder, you'll receive an email this week with information about how to access your CME credit for this session. Thank you.
Hello, everyone. Welcome to the IAOS 2021 webinar on airway and gastric point of care ultrasound, POCUS in anesthesia. My name is Eric Yutan, associate professor in the Department of Anesthesiology and Pain Medicine at Mount Sinai Hospital, which is affiliated with the University of Toronto, Ontario, in Canada. I have no conflict of interest and any disclosure. The outline of this webinar will be presentations by expert speakers with 3 speakers to provide the evidence, technique, decision-making, and management in the use of gastric and airway POCUS in anesthesia. After the presentation, there'll be a live session of questions and answers. Over the centuries, there have been many tools that has been used in medicine. And one important tool that was invented by Linac is the stethoscope for its diagnosis of cardiovascular as well as pulmonary pathologies. And the stethoscope has been modernized over the past decades into the late 20th century into the electronic stethoscope. However, in the 21st century, portable ultrasound has become increasingly being used in the field of medicine. In fact, in the 21st century, ultrasound, or the POCUS, has been known as the visual stethoscope in many fields of medicine as well as anesthesia. The right graph depicts the increasing publication of POCUS, and you can see an exponential growth for the past 2 decades. When you do a PubMed search On auscultation, you'll have about 12,000 results, and auscultation has been around for many decades, as compared to point-of-care ultrasound, which is close to 10,000 results and only been around for about 2 decades. This highlights the increasing use of point-of-care ultrasound, or POCUS, in anesthesia as well as in other fields of medicine. While point-of-care ultrasound can be used in many system organs in the body, this seminar will focus on airway, particularly upper and lower airway. In addition, we will also focus on gastric ultrasound. Our speakers are experts in these fields, and the speakers are Dr. Cristian Arzola, Dr. Naveed Siddiqui, and Dr. Fabricio Zasso. They are all staff anesthesiologists in the Department of Anesthesiology and Pain Medicine at Mount Sinai Hospital, affiliated also with the University of Toronto in Canada. The speakers will provide so that you become familiar with the evidence, technique, decision-making, and management of the role of gastric and airway POCUS in anesthesia. We will highlight the use of POCUS using a case scenario, which involves a 45-year-old male of BMI 40 who is scheduled for a fasciotomy 24 hours after repair of an open femur fracture following a bicycle accident. The patient's C-spine has been cleared. And on physical examination, you also notice that the patient has developed an ecchymosis on the anterior of the neck. Airway exam reveals a Mallampati fall, and he was previously intubated with a glide scope. How would the use of gastric and airway ultrasound be helpful in this scenario, in decision-making and management plan? In this case, the use of airway and gastric ultrasound can be used in the preoperative period to determine and assess gastric content, also to assess airway trauma and the airway landmarks. These will provide the indication for decision-making as well as airway management plans. Furthermore, intraoperatively, POCUS can be used to differentiate between tracheal versus esophageal intubation, and also to diagnose life-threatening events where the appropriate management can be provided. Lastly, post-operatively, POCUS can be used to determine and assess airway complications, and more particularly to this scenario, it can be used to determine vocal cord injury or vocal cord palsy, and likewise is to determine and assess life-threatening events such as a pneumothorax. I will stop now, and the presenters will provide their presentation. And as a reminder, there'll be also a live question and answer period.
My name is Cristian Arzola, and the topic is gastric ultrasound. I have no disclosures for this presentation. The first question in decision-making is why gastric ultrasound? Any good prior to induction? Is 8 hours fasting sufficient for gastric emptying? And my answer is that gastric ultrasound can help us to determine the gastric content, regardless of the hours of fasting and many other conditions. We have guidelines, in this case from the American Society of Anesthesiologists, but we know that sometimes these guidelines may not apply to certain circumstances, and the aspiration risk need to be avoided and decreased by preventative strategies beyond the guidelines. The NAP4 major complications of airway management in UK showed that aspiration of gastric content was still an issue as the first cause of anesthesia airway-related mortality with poor management, and a very interesting finding was inaccurate assessment of aspiration risk. The incidence of aspiration varies with different reports, but the baseline risk has been estimated to be 1 in 4,000 cases. The most recent report is a closed game analysis. It's still online. We have an editorial in which we try to make a case for gastric ultrasound as a useful tool. We know that these reports have limitations, but from this report, we understand that the anesthetic practice was judged substandard up to 60% of the cases. When fasted, it's not empty. Even for elective patients, we can find full stomach with the presence of solid and significant amount of clear fluids. But one thing is empty stomach and the other extreme is full stomach. In between, we have different states that we have to consider. But what happens when we do ultrasound and we find full stomach despite fasting? This study is a provocative study about orange juice with or without pulp. The gastric ultrasound, what do we do with this? One of the suggestions is that useful in ambiguous situation and may have a role in future guidelines. Hopefully, I have responded succinctly the benefit why gastric ultrasound is useful in decision making. Second question is how. In this particular patient, we have a significant amount of food. What is the evidence for this and scanning technique? This is a narrative review. It's an open access article in a special issue of Canadian Journal of Anesthesia. We're going to explain our gastric ultrasound in IM framework. First, indication. It's a bedside assessment. It's a limited examination, goal-directed to determine aspiration risk, and it's performed by us, clinical anesthesiologists. In the acute setting, when we have doubts about the NPO status or any condition that can alter gastric emptying. It's in supine and right lateral decubitus. We can add 45 degrees semi-recumbent in the epigastric area with a curvilinear array probe in abdominal settings. The interpretation is all about pattern recognition, qualitative, to determine the nature of the gastric content. The second aspect is quantitative, to determine the volume estimation only when you have clear fluids by measuring the cross-sectional area. Sagittal view. This is a pregnant patient that is feasible. You're going to go through the liver, the left lobe of the liver, in order to access the antrum. And the sun anatomy that is relevant is the aorta at the bottom. On the side, you have the liver, and along the free border of the liver, you have the antrum. Here are some images. The antrum, an empty stomach, very small. We call it bull's eyes. This is a more dynamic image. When you have clear fluids, you will have hypoechoic image, dark. As you increase the fluid, you may have more air in the stomach with these white dots, air bubbles. When we have solid content, the air is going to be very significant. As time goes by, you're going to be able to see again the gastric walls. But this is something you don't want to see in your patient, a stomach full of gastric content. How good is this pattern recognition? Well, we have done studies in adults, pregnant patients, and also obese patients, and it's very reliable. When we do qualitative, it takes around 30 cases to learn to do this technique. And the cross-sectional area can be measured with two methods, two diameter, also free tracing. When we do this with free tracing, it's very reliable when we measure it under different circumstances and different raters. By measuring the area, you can estimate and predict the volume. This was developed under a study that determined a predictor model where you input the age and you can determine volume based on the area. This is the assessment. First, you start with qualitative assessment. If it's empty, low risk for aspiration. Thick fluid, solid content, high risk. Only when you have clear fluids, you go to the second aspect of quantitative assessment and you measure the area of the antrum. And from there, you can estimate volume. If it's more than 1.5 ml per kilo, it's estimated to be high risk. If it's lower than that, it's low risk. This is the algorithm of assessment with the gastric ultrasound. You put all the different variables together, plus the gastric ultrasound information, and you're ready to do decision making. In elective patients, for example, when they do not follow fasting guidelines, in this particular study, they did gastric ultrasound in 70% of the cases that were able, with the information, determine perianesthetic change, even time to proceed, or anesthetic technique. But when you have surgical patients, not elective, with an elevated risk of aspiration, with a high risk of aspiration on clinical judgment, with many hours of fasting for solid or fluid. You do gastric ultrasound that takes around 3 minutes in the study. Not every patient was feasible to do a good ultrasound, but they found that half of the patient were high risk and the other one was low risk. This is a proof of concept that maybe by doing gastric ultrasound, you can determine beforehand the risk of aspiration and may change your airway management. In the past, medicine was difficult to incorporate different tools. I believe gastric ultrasound and beyond that, point of care ultrasound can help us in our daily practice. This is a website, educational, open access. I highly recommend it. Thank you.
Hello, my name is Naveed Siddiqui, and I am presenting upper airway ultrasonography for the IRS webinar series 2021.
I don't have any conflict of interest, neither am supported by any sponsors of this meeting. There are many applications of ultrasound in upper airway management. In this brief presentation, I would give an overview of the important applications for upper airway ultrasonography and talk more in detail on the ones that are more important and backed by strong evidence. Also going to touch upon some applications such as identification of neck pathology, hematoma, and prediction of difficult laryngoscopy using ultrasonography. As anesthesiologists, one of our worst nightmares is the unanticipated difficult airway, leading to a cannot intubate, cannot oxygenate scenario, and the need to perform front of neck access. All difficult airway algorithms by different societies for cannot intubate, cannot oxygenate situation lead to cricothyrotomy, and success of which is highly dependent on identification of neck landmarks, in particular the cricothyroid membrane. In thin and lean subjects, cricothyroid membrane may be easy to palpate. It is located between the thyroid and the cricoid cartilage. Traditional methods of locating cricothyroid membrane is by using 4 fingers for digital palpation and by guesstimating using the neck folds. However, in many patients, especially the ones who have some features of difficult airway, identification of these landmarks is not possible. And in these cases, the recommendation by Difficult Airway Society is to make a 8 to 10 centimeters long incision, which saves lives but had a potential to cause more morbidity. Palpation of neck landmarks is not that easy. There are quite a few studies comparing the ease of identification of neck landmarks in different subset of patient population and care providers, including trauma surgeons. Interestingly, none of the physician groups the trauma surgeons or the anesthesiologist are good in identifying the correct position of the cricothyroid membrane. The overall success rate using palpation to identify cricothyroid membrane was less than 50% in this study, with only 16% of the anesthesia provider and 26% of the trauma surgeons being able to locate it accurately. Comparing conventional palpation with ultrasound, it is clear that ultrasound improves accuracy across all patient groups. This includes pregnant and obese patients. Ultrasound not only improves accuracy, but it also does improve outcomes. In a study by our group, we asked anesthesia providers to perform cricothyrotomy on cadavers and compared the group which used ultrasound versus those who used traditional palpation method. Ultrasound increased the success rate by 5.6 times and reduced the complication with relative risk reduction of 2.9. In another study of ours, we used only the subjects that had poor neck landmarks. Again, ultrasound was superior and inaccurate localization of cricothyroid membrane was 9-fold greater in the palpatory technique for this study. There is a structured approach to identify cricothyroid membrane initially described by Michael Christensen. Identification is based on transverse and longitudinal application of ultrasound probes on the neck. On this slide, you can see the orientation of the probe along the neck. As you move along from suprasternal notch towards the thyroid cartilage, you would see the tracheal rings. And as you move towards the head, you would see the first cartilage appearing as a hyperechoic structure, which is the cricoid cartilage. And then you would see the thyroid cartilage and anything in the thyroid membrane. It's easy to remember the acronym TACA. This is rapid identification of the cricothyroid membrane in a transverse orientation, where you identify the thyroid cartilage by placing the probe on the neck. As you move down, you see an airline, which is hyperechoic structure. You move further down, you would see a hypoechoic structure. This is exactly your cricothyroid cartilage. And then as you move down, you would see the airline again. As I mentioned earlier, strings of pearls can be identified in a longitudinal way. You can slide a pin or a metal object underneath the probe to exactly mark the membrane. Many studies, including systematic reviews and meta-analysis, have been published on the topic of confirmation of endotracheal tube, especially in critical care and emergency medicine literature. These reviews suggest a high sensitivity and specificity of the technique, both above 98 and 97%. And this was studied across extensive subgroup of patient populations. Basically, ultrasound is used to rule out esophageal intubation. The trachea appears as a hyperechoic curve linear with a comet-tail artifact. The esophagus is more distal, oval, and hyperechoic walls with a hypoechoic center. Ultrasonic endotracheal tube confirmation can be done in real time as the tube is being placed or done post-placement. For successful endotracheal tube placement, there will be a slight increase or artifact showing the tracheal region, also known as the bullet sign. The operator should see reverberations in the tracheal interior lumen. To further confirm, we can slightly shake the endotracheal tube. This should only show trachea movements. When endotracheal tube is in esophagus, it is also known as double track sign, as you can see on the left of this figure. Esophageal intubation will cause a second trachea to appear, referred to as a double track sign, also known as a goose sign. One of the pitfalls here, and thing to remember, is that esophagus may be located directly posterior to the trachea. Therefore, esophageal intubation may be missed if inadequate depth of ultrasound is used. The upper airway ultrasound can be used to identify neck pathology to make perioperative decisions. In this slide, you can see the probe placed transversely over the middle portion of the thyroid cartilage. You can see the vocal cords up here and arytenoid cartilage down below. On this slide, figure on the right shows normal abducted vocal cords, and figure on the left shows adducted vocal cords. This can be rapidly done to make perioperative decisions regarding vocal cord pathologies. You can also identify small or large neck hematomas on the ultrasound. There is a growing evidence for the use of ultrasound to predict difficult airway. This is done by identifying the cartilaginous structures and measuring depth of adipose tissue from the skin. As I said, the evidence is not that strong at the moment, but it is growing, and hopefully in future, we would be able to use ultrasound to predict accurately difficult laryngoscopies and intubations. Thank you.
Good afternoon. My name is Fabricio Zasso, and I'll be presenting the topic lung ultrasound on the 2021 IRS webinar series. I would like to say that I have no disclosures. The learning objectives of this session are understanding basic principles and recognizing normal and abnormal images on lung ultrasound. These are the sources used for this presentation. It includes a review from the OB Anesthesia group at Mount Sinai Hospital in Toronto, and 2 articles from the St. Michael's Hospitals, also in Toronto. One article focused on the IAIM approach, and another excellent review was published on Canadian Journal of Anesthesia in 2018. In terms of images, I used 3 online sources that I highly recommend: the POCUS Atlas, Foresight Ultrasound, and PIE, Perioperative Interactive Education from the University of Toronto. First, we must provide some general considerations about basic principles of lung ultrasound. Any type of probe can be used for lung ultrasound, with depth varying from 4 to 6 centimeters with the linear one and up to 16 centimeters with the curvilinear one. The patient can be either supine or in the semi-sitting position. As you can see in the image, there are different protocols regarding how many windows should be assessed, varying from 6 to 28 zones. The decisions of which probe, position, or zone approach to use is guided by what the scanner wants to assess. Regardless, the probe must be positioned perpendicular to the long axis of ribs. The classical image will be 2 ribs at the edges of the image. In the middle, from the top to the bottom, we have the muscle pleural line, here represented by the blue line, and lung tissue. When visualizing the pleural line, we can see movement. In this image, the arrows indicate the parietal and visceral pleura sliding one on top of the other. This is called lung sliding and is a normal lung image. In this video, we can first see a rib and a shadow. And afterwards, the transducer moves, and there is the lung sliding, which is the bright line moving. Above the pleura, there is muscle tissue, and below is the lung tissue. The next image is the seashore sign obtained on M-mode. The top portion resembles sea waves and represents soft tissue without motion. The bottom resembles sand and represents the lung tissue in motion. On this slide, we can observe the A lines. On the left image, they are the horizontal yellow lines, while the green line is the pleural space. A lines are artifacts that indicate normal lung tissue. They are reflections. The distance from the probe to the pleura is equal to the reflections towards the bottom of the image. The middle image on this slide shows A lines on a linear probe, and the right image on a curvilinear probe. Here we can see a video showing lung slide, represented by the white arrow, and an A line, represented by the blue arrow. The next video shows the lung pulse, another sign of normality. It represents the reflection of heartbeats on the pleura in a rhythm movement. Transitioning to abnormal lung images, we have B lines. B lines are long horizontal lines, also called comet tails. Up to 2 B lines in the one intercostal space is normal. Above 2 B lines in the same or more than one intercostal space means abnormality, such as interstitial disease. B lines should be from 10 to 15 centimeters long. Therefore, it's easier to confirm than by a curvilinear probe image. Shorter comet tails are called Z lines and are just artifacts. Here we can see B lines in a linear on the left and curvilinear probe on the right. Here we can see a video with B lines around the hip and its shadow. We can see them. Note how long they are. Lung point is the point in a view where a normal pleural pattern transitions to an intrapleural air pattern. We can see that on the left image, when the space between the red and yellow lines get wider. It confirms the diagnosis of pneumothorax. In the right image, we have the image of one intercostal space where pneumothorax is fully present. In that situation, lung sliding and lung pulse are absent. However, we need to be aware that for finding the lung point, several windows need to be scanned. This last image shows the pattern that pneumothorax creates on M mode, the barcode sign. It all resembles C waves. On this slide, you can see a video. I would like to look first to the right side. It shows pneumothorax in B mode. First, we're going to see a rib and a shadow. As it moves to the right, there is no movement. Another rib and shadow, and then you can see pleural movement. But just when it moves to the right, the movement stops. So let's say that this transition is the lung point. On the left, I want to show you where the image transitions from a seashore pattern to a barcode, and this is the lung point. On this slide, you can see that going back to our case scenario, we should assess pneumothorax, endobronchial intubation, and other hypoxic causes, such as negative pressure pulmonary edema. Here you have a table showing what is present and absent in each condition. The presence of A lines and lung sliding indicates normality. Lung point means pneumothorax. The absence of lung sliding in a whole hemithorax points out to endobronchial intubation. B lines would indicate interstitial disease. When you have pulmonary edema, they will be present bilaterally on dependent regions. We must always consider if the disease is limited or diffused on our differential diagnosis, and according to that, we should scan more or less windows. Thank you very much, and we are open to answer questions.
Okay, thank you. I'd like to thank the speakers for their presentation. And this is the live Q&A session. So if anybody has any questions, I would like you to put it in the Q&A. Just going to give you a few seconds for those who are just gathering their thoughts for the questions. I believe there was a questions that was in the Q&A and was answered, but I think I will share it with the group in case those who didn't see it. The first question was probably addressed to Dr. Arzola on how to best locate position probe for gastric ultrasound.
As it was mentioned in the presentation, the best way to locate the stomach is usually with the patient in supine or right lateral decubitus. And you put the probe in a longitudinal axis, and it's going to be a sagittal to parasagittal view, trying to use the left lobe of the liver as an acoustic window. That is the most appropriate. Sometimes when you put the patient in 45 degrees semi-recumbent position, you can increase the sensitivity of your exam because every content, a small amount of content is going to go to the lower part of the stomach, which is the antrum. So you can optimize and maximize your scan.
Okay. If anybody has any comments on this, you can speak up. Otherwise, I will proceed to the next question. It's an interesting question. Somebody asked whether the Mendelssohn criteria with regards to pH has now become irrelevant because of the use of gastric ultrasound. And again, I think this question is probably directed to Dr. Arzola.
Okay, so concerning the Mendelssohn traditional criteria, pH 2.5 is still relevant. Particular matter, gastric content that is solid is still, of course, is relevant. But something has been questioned, and by gastric ultrasound research, it's the volume. We have to understand when you go back in the studies, the volume that was instillated in certain animal models, it was very small of volume, and it was directly into the trachea, and that would allow to have this pneumonitis. And it was as low as 25, 50 mL, different studies, and even later they say 0.4 to 0.8 mL per kilo. But we have seen over the years different type of research, and now we're being more acquainted with ultrasound studies, that most of the patients after a regular fast or accepted fast of 8 hours or more will give you 1.5 mL per kilo. So most of the patients that we put to sleep every morning for surgery, they may have 1.5 mL per kilo as a baseline gastric secretions. So it seems that if we follow the volume criteria from Mendelssohn, we really get into a high risk of aspiration every patient we have in the morning for our elective surgeries. So it seems, and we're moving forward with more evidence for that, that 1.5 mL per kilo could be the cutoff point for volume to say that it's low risk of aspiration. And this is important, it's low risk. I'm not saying no risk. It's about probabilities.
Okay, so there's two back-to-back questions by Kumar Bilani. One is whether the patient should be on the right lateral position, and what is the best probe when you're using gastric ultrasound?
For gastric ultrasound, the best probe is the curvilinear probe in abdominal settings. And first you start in supine, and then you put in right lateral decubitus. When you have a patient right lateral decubitus, you're gonna have the real information from the stomach. Why? But that will happen when you have a small amounts of fluid or a small amount of food. When you have a patient in supine, the stomach is like a balloon, and the food or the liquid will spread out. But when you have the patient in right lateral decubitus, you're gonna optimize first gastric emptying, that is well known for physiology, and all the food will tend to go to the antrum. It's where actually we do the measurements and we do the actual better assessment. The antrum is a good surrogate of whatever is happening in the rest of the stomach. Of course, if you have a lot of food, any position will give you information about the gastric content. You can have a patient in a standing position,
and you will be able to scan stomach content. But when you have smaller amounts, when you want to be a more discrete amount of gastric content, right out of the cubiture will be increasing your ability to detect what's actually in the stomach. And when you have the patient 45 degrees recumbent, even more. And that especially we do it in pregnant patients.
Actually saw an interesting question from Ricardo Serrano. I'm just going to present this as the last question for the gastric ultrasound and then go on with the other speakers' question. This question addresses if a patient has NPO violation, but a gastric ultrasound is performed showing an empty stomach, do you proceed even though you're not following the ASA guidelines? I suppose the question addresses whether the 8-hour guideline is violated or not, even though the ultrasound showed probably an empty stomach. Should you proceed with a normal induction instead of a rapid sequence?
So something important to mention. So if I do the gastric ultrasound, it's because I have a doubt about the NPO status of the patient, or if I know exactly that the patient had NPO violation and the stomach is still empty, I need to be sure that it's a good image. But we're always under guidelines. I'm going to have this as another piece of information in the decision making. To be honest, I will still have the patient within the guidelines, but if I have an empty stomach and the patient had NPO violation, this is a very broad question. I would like you to subject to the article, editorial, very thoughtful editorial, when said, when your stomach is full stomach despite fasting, which is the opposite extreme. But if I have a stomach that is empty despite no following the guidelines, it depends on the surgery, it depends on the other risk factors, and we put everything together, and so you cannot answer yes or no, but I will follow guidelines in most of the times. But if I have a gastric ultrasound that is empty and it's really empty, and I have no doubts the good imaging, I will see the other risk factors in the patient, and I will make a decision with the surgical team as well, and make them to be in the same page, and also the patient. But I would prefer to wait the time that's needed according to guidelines, because the gastric ultrasound, even though it's very good, the positive predictive value can be 95%, and the negative predictive value, or let's put it another way, if you have a stomach that's empty, what is the probability of being with some food inside is 0.1%. Okay, so gastric ultrasound is something that's coming into play in our daily practice that has to be incorporated slowly in order to do it properly.
Okay, I'm just going to now proceed to some questions related to the upper airway ultrasound. Shirley Santos has asked an interesting question, is what is the role of airway ultrasound in an emergency airway? And I think this would address more to Dr. Siddiqui, rather than in a pre-procedural situation. How would this be useful in an emergency situation?
Okay, that's an excellent question, and definitely we're expecting that. So majority of the studies are done where we identify the cricothyroid membrane in a pre-procedure scenario. And in fact, now with the DAS guidelines, it is also recommended in your anesthetic technique, you should mark the cricothyroid membrane. Either you're using transverse approach or you're using longitudinal approach, but you should do it preoperatively before whatever your method of induction of anesthesia would be. And in terms of emergency, as you get better in learning the technique, you can use a transverse approach. There are at least 2 case reports which came up recently in scenarios of cannot intubate, cannot oxygenate. They used ultrasound, and they showed that there was enough time to do ultrasound within 30 seconds. They were able to identify not the cricothyroid membrane, but the first and second tracheal rings, which helped in oxygenating the patient. So yes, it does improve outcomes, especially in the emergency situation as well. But it depends on how proficient you are in using ultrasound for this particular emergency scenario.
Okay, thank you, Dr. Siddiqui. On a similar note, Christodoulos has asked, scanning the esophagus to confirm for the absence of endotracheal tube needs to occur on both sides of the neck, as the alignment of the esophagus relative to the trachea is highly variable and not predictable. What are your thoughts on that?
Yeah, that's true. You know, like, and as I mentioned, probably my voice, and I apologize, was a bit low on the video, that you have to use appropriate depth on ultrasound probe in order to see the posterior aspect of the esophagus. And it can appear on either side of your ultrasound. But as I indicated, you know, like the intubation technique in itself, if you have put the ultrasound probe on the suprasternal notch and you are doing your scan in real time, you would be able to see reverberation artifacts in the trachea when the endotracheal tube is passing through the vocal cords. You would also see, if the tube is in the esophagus, a double track sign. And so in some studies, people have used the saline to fill in the endotracheal cuff, which a combination of saline and air in the endotracheal cuff does have a characteristic appearance on the ultrasound. So it's a dynamic process. And if you are not in the esophagus, you are in the trachea. And my fellow Fabricio can allude to it about the B lines or for the confirmation of the endotracheal tube. A lot of literature comes from our emergency medicine physicians and our ICU physicians who use this technique quite regularly.
Yeah, I think, yeah, thank you, Dr. Siddiqui. I think this also leads to Chris' initial suggestion that putting saline in the cuff has been used to identify the position of the trachea. And I think Dr. Siddiqui had just alluded to this. And I agree with Chris that this is a very good signal when you put saline in the cuff. So absolutely, I both agree with both of your comments. Moving forward, there was a question regarding the recommendation for identifying the cricothyroid membrane during predicted awkward airway patient during both elective and high BMI patient. So what is your recommendation, Dr. Siddiqui, for the cricothyroid membrane?
Yeah, so any difficult and anticipated difficult airway, it is advised that you should mark the cricothyroid membrane. And I see in the chat there is a question about in which position should we mark the cricothyroid membrane, whether it should be extended position or a neutral position. Initial literature came out in neutral position, but now there is a consensus that you should do the surgical airway in an extended position, and you should mark the cricothyroid membrane in the similar position, which is the extended position of the neck.
Okay, thank you. I think I'd like to have a question for Dr. Zasso. There was a question from Mukesh Nigam about how to scan the lungs with the probe, the transverse or the longitudinal approach.
So the approach for the lung ultrasound will be always longitudinal. We need to have in mind that sometimes can be tilted a little bit. Why is that? Because it's not all about what's the position of the probe, but what the image that we want to have. We want to have on one side of our image, one rib and the shadow, on the other edge, on the other side, another rib and shadow. And in between will be the lung tissue for us to evaluate and the pleural area as well. So as you can remember from my presentation, sometimes during the videos, the person that was doing the assessment first started with the rib in the middle. So this is more for like a orientation purpose, but then they move the probe a little bit cranially to see that space. And just to complement what Dr. Siddiqui said before, I think lung ultrasound is something that's really, really useful for us in situations that we have endobronchial intubation, and we as anesthesiologists, we know that this can happen during the case, right? Let's say that you have a high BMI patient for a laparoscopic case, we start the case, we intubate, you check the intubation, you have positive capnography, the inspiratory pressure is not high, and you also take the lung is bilateral. But once the surgery starts, let's say that's for a pelvic surgery, gynae surgery, and you have like a deep liver and have pneumoperitoneum, sometimes you can have endobronchial intubation, right? So this is a situation that's you have your patient like on the head down, it might be a different intubation. You don't want to risk to extubate this patient accidentally. So you can even do real-time lung ultrasound as you retract a little bit your tube, because if you suspect that and you analyze in 2 or 3, 4 spaces, just after intubation, and you don't have any lung slide, this patient most likely has an endobronchial intubation. And then you can retract and at the same time check with the ultrasound, and as soon as you have like lung slide, you can restart. So I think that's a really good application of lung ultrasound in our daily practice.
Okay, an interesting question from Tezen Beg, who asks regarding the placement, what would you place the lung ultrasound probe in a trauma patient with multiple broken ribs?
Yeah, that might be a limitation of technique, right? If you don't have the anatomy really distorted by the broken ribs, then you're going to be able to do the ultrasound. But if you really distorting the area of the broken ribs, most likely you're going to go to other areas and avoid that. Remember that as I showed, you have some approach, the zones that need to be scanned. So more when you have like an emergency, you're going to have 6 or 8 zones that are more anterior. But when you have like more an elective, you can do up to 28. So you can change from intercostal spaces, or even like change from parasternal line or mid-axillary line or posterior axillary line to try to have the image and see if you have a pneumothorax. But of course, in this situation, your exam will be limited.
Okay, this is, thank you, Dr. Zasso. This is a questions from Muniz Abzoudira. It could be either from Dr. Siddiqui or Dr. Zasso. How can you diagnose endobronchial intubation? Is it by lung or airway ultrasound?
I would say that the better approach would be lung ultrasound, right?
Yeah.
You agree?
Yeah.
Yes.
With upper airway, I don't think that you would be able to see the right main bronchus. You would be able to identify the endotracheal tube by looking at the lung sliding on one side, and on one side there won't be much lung sliding.
Yes, exactly.
Yeah.
That's exactly right. So we're not going to have a lung slide, right? It can be a confounding factor with pneumothorax, but probably pneumothorax will be not the whole hemiplegic. So we can scan more areas, and then you're going to see. And then, of course, always when you use lung ultrasound, you need to correlate with the clinics, right? So the clinic will give you a guide. When you look into the IAIM approach, the interpretation and medical decision is always correlated with the clinics that you have. So the clinic will give like a suspicion, like is this like a pneumothorax or like a endobronchial intubation, and then the lung ultrasound will help you to define. And decide which approach you have to go to that after that.
Yeah, I would say I agree with both with Dr. Zasso and Siddiqui. In fact, there was a randomized control study by emergency physician group, which purposely intubated endobronchial, and then has the emerged resident auscultate versus ultrasound, and ultrasound has been shown to have a higher prediction of which side was endobronchial intubation purposely. So ultrasound has greater positive and sensitivity, positive predictability compared to auscultation alone. So that was a good study by an emergency physician group, and it was a randomized control study. Interestingly, I think there was a lot of question regarding the gastric ultrasound, and I think we have about 5 minutes. I might take 2 questions. Let's see here.
I've been answering a few ones through
Yeah.
the chat as well, so you can choose any.
So I will choose one. Obviously, an important question and an important patient population that is always worrisome for us anesthesiologists is the pregnant population. And this is appropriately asked by Mercedes Vargas. So the question is, I guess, addressing to Dr. Arzola is, in the case of a pregnant woman, there are several mathematical models studied. Which one do you recommend to use in daily practice?
So concerning mathematical models to estimate qualitatively the volume of the stomach, and just to emphasize, the volume of the stomach is something relevant when you have clear fluids. Another question is trying to address the issue, and I want to mention that when you have a full stomach, it means you have any amount of solid food or any amount of thick fluid or any clear fluid more than 1.5 ml per kilo. And an empty stomach, we say when it's really empty, you don't see anything in the stomach, or less than 1.5 ml per kilo. Concerning pregnant patients, first, I want to let you know that we use it on a regular basis for pregnant patients. It's feasible. We demonstrated in our local studies that you can still perform gastric ultrasound confidently. And the numbers, the scanning, everything is quite similar. You have to understand the stomach is pushed upwards and to the right a little bit, but still adjusting a little bit of the technique, you will still be able to scan the stomach. The mathematical model, the initial or the most significant model that we have is the one developed by Dr. Naveed Siddiqui. That model was not validated in pregnant patients. So we did our own study trying to get a mathematical model. But the model was trying to validate it with some ingestion of fluid. And then, long story short, the statistical management showed that it's quite close. There's another mathematical model that was done with MRI by a European group, and also trying to go closer. At this point, we're working in some meta-analysis and some information to really try to validate based on big databases that the information that we gather with the conventional mathematical model developed by Dr. Perles could be still good enough to use in pregnant patients. It's still a question we have to answer more definitely in the near future.
Okay, so nearing the end, I want to ask one more question, which I thought is an interesting question, again, related to a specific patient population. And this is by Karthik Raghunathan, who asks, is there a valid method to determine large gastric residual volume in ICU patients that are anteriorly fed?
Well, yes, we can use gastric ultrasound in any patient, but there's a caveat here. When you try to determine residual gastric volume in the stomach, the best approach is when you have a patient in right lateral. When you measure and you do a cross-sectional area and you estimate the volume with the patient in supine, we know for many studies that we're going to be underestimating the volume. So you want to be more certain about the volume, you need to have the patient right lateral decubitous. So here's the point. If it's not feasible to have the ICU patient in right lateral decubitus, most likely the supine measurements is going to be an underestimation. And we don't know by how much. Only when you have the patient right lateral, you're going to be able to measure and use the mathematical model that is validated for right lateral decubitus. Supine, unfortunately, is not good. But if you're able to have the patient right lateral decubitus and measure, it's going to be a reliable measurement, provided you don't have abnormal anatomy, as one of the questions suggested.
Okay, I think this wraps up our webinar on gastric and airway POCUS in anesthesia. Again, we'd like to thank you for participating and with your very thoughtful questions. And I hope we have addressed most of them, either through the live chat or through typed answers. And again, if you have any question, you think you can reach us by email, and we'll be happy to answer them. Thank you all for joining us.